cancer, and obviously male breast cancer, and we kind of talked about that earlier, inflammatory, all this stuff about endocrine sensitive, H2, HER2 positive, metaplastic. There's all these different subtypes. So a lot of these, what that really means is that it just sort of gives you a better picture of where your breast cancer's at. So there's all these different markers that they can do to determine whether or not you have, for example, the tumor is sensitive to estrogen and progesterone, or whether or not it's actually an inflammatory breast cancer. I mean, there are different ways to diagnose that, and so there are blood tests that need to be done, and also on pathology. So that's just sort of a list of all the different areas that breast cancer can kind of go out into. If we look at causes, family history is a strong indicator of breast cancer. That's why they're now really pushing people to get that BRCA1 and BRCA2 testing done. Anybody over the age of 50, there are some genetic mutations that have been known to increase your risk. There's also people that are obese are at high risk. Girls that have had pregnancies actually before the age of 15 and multiple pregnancies before the age of 15, it really increases your risk of breast cancer. Girls that have started their periods before the age of 16 is sort of an indicator. And all of this stuff, I mean, the literature changes. What I found, at least in my research studies, is looking at this, is really it changes from day to day. You can go to one study at Mayo Clinic and it says, you know, if you've had 2 kids before the age of 16, and then another study says, well, if you're, you know, overweight and your BMI is X. So there's a lot of data out there, and it's really hard to sort of discern exactly what that means to the general population, but these are the basic things. There is a breast cancer risk tool that people can go to. That's cancer.gov, and it's very good at sort of discerning whether or not you're at risk for breast cancer. It's very basic. So if we look at our surgical options, basically patients can opt, and Tom, please tell me if this is wrong or not wrong, because you helped me with this. Patients can either opt for having a mastectomy, and with the mastectomy, they can get reconstruction or not reconstruction, either at the time of surgery or later. Patients can also opt for having just a lumpectomy with chemotherapy and radiation. So there's several choices for them to make at the time of diagnosis. It also depends on the size of the tumor. If the tumor is really large, the physician may say, you know what, you need to have chemotherapy first. Try to shrink this tumor down before we even opt to operate on it. Because a patient may be looking at having a mastectomy with a large tumor, but if chemotherapy and radiation can shrink it, then they might actually be able to have a lumpectomy. So is that true? Am I being accurate?
Yes.
Please?
Yes. So the choice is if you choose to have a mastectomy, you're saying that you're opting out to not having radiation treatments in general. The concept of lumpectomy followed by radiation are the breast conservation therapy. And most women opt for lumpectomy with radiation rather than mastectomy because they preserve the breast. There are women that choose not to want radiation therapy, so therefore they would prefer to go the mastectomy route. The essence of it is that whether you choose a mastectomy or a lumpectomy with radiation, the recurrence rate to the breast or to the chest is the same. So you can't go wrong with any of those options.
And I know the people that tend to, at least from my own personal experience and from what I've read in the literature, people that opt for a mastectomy versus just having, people would say, why would I have a mastectomy if I could just have the lumpectomy, meaning just a portion of my breast taken out, a small lump taken out with radiation and chemo? Why would I do that as opposed to lopping off my entire breast? But there are people that are very small-chested who actually actually might have burns and more side effects from the radiation than just having the mastectomy with reconstruction. So if we look at the lymph node biopsies, so at this point, if a patient is in the operating room, they're going to have a sentinel lymph node biopsy done. And there's this mapping procedure. They get a wire put in to make sure that it's actually the right lymph node that they're taking out, that feeds and drains the rest of that area. So if they get that sentinel lymph node mapping and that sentinel lymph node is then positive, meaning that it does have cancer cells in it, at that point, while they're in the operating room, they will take out more lymph nodes to see if, and that's where you go to the multiple nodal dissection to see if whether or not, there are, let's say you're able to get 6 lymph nodes and 3 out of the 6 are positive. That gives them an idea of how much that cancer is actually spread versus no lymph nodes being positive. So this TNM system is very common in all the literature. It's based on the tumor size, how many lymph nodes are involved that are taken out, and how much metastasis or not metastasis there is, meaning has that cancer actually spread beyond or not beyond the actual area involved. So when they stage patients, they will look at all these factors and then they get staged based on that. Their chemotherapy regimen will be guided based on what their staging is, as well as several other things. So if you look at how patients are then treated for the cancer, their breast cancer, they look at not only that staging system, but they look at the hormone receptor status, the HER2, and the tumor markers. So these are 3 different things that they kind of look at to see whether or not or how they're going to guide this treatment. So the hormone receptor status is basically whether or not, what they have known is that cancer cells are really fed by estrogen, especially breast cancer. So if their hormone receptor status is positive, then they're going to guide the treatment one way. HER2 is the same thing. That is actually a cell protein. It's on every cell. But if that is positive, that means that basically and I'm going to get this screwed up because of the HER2 and the hormone receptor. So I'm deferring to you for this.
Okay, so if HER2 is basically
without looking at my notes,
it's a cell protein. So being positive meaning that this hormone or this cell protein is overly expressed. It being overly expressed means it's a much more aggressive tumor. So there is a different chemotherapeutic regimen that's associated with the treatment of HER2 positive breast cancers versus someone who is ER or PR positive. And prognostically, HER2 positive tumors are worse than ER, PR positive.
So the oncologist basically does all the testing on the actual tumor cell. Okay, so they take it, they send it to pathology, it's checked for, the HER2, the hormone receptor status, and then they actually draw blood for tumor markers. So they look at the CA, they look at CA levels, CA2729, and these are all tumor markers that have been basically determined that in breast cancer, it means that you're more likely to either have tumor or your therapy is working or not working. So I had a patient actually call me today and say, and she actually has colon cancer, but she said, it's very interesting to me that my doctor cannot tell me whether or not after 3 treatments, and I have 10 more to go or 9 more to go, whether or not my cancer is shrinking. How am I going to know that? And I said, that's very interesting. It's a good question because they can do these tumor markers, they can check your CEA levels and et cetera, but are you really going to know that? I mean, the CEA levels are there for a reason. We know that they show us some indication of tumors and, therapy working, but it's not really very accurate. And that's kind of where IV diagnostics and the Foundation for Molecular Medicine really comes into all of this, who is, sponsoring these talks, because they're the ones that are trying to go out and get, they're doing nanotechnology so that we can actually look at drawing blood and looking at cancer cells in the blood and counting the levels, as opposed to looking at these markers that really don't mean a whole hill of beans. I mean, that's the basic thing. So when they draw blood for these levels, patients can be sky high, and the doctor may say, you know what, we need to give them more chemo or change their chemo regimen or, whatever, do more surgery, and it may not really mean that that's what they need. So we really don't know. I mean, it's very inaccurate. So it doesn't mean that they shouldn't be done. It's just that the testing at this time and date isn't as good as it needs to be. And that's kind of where the foundation comes in